So welcome everybody, and thank you so much for joining us. My name's Katie Pryor. I'm the manager of the education team here at the Western New South Wales PHN, and we're really pleased you could join us for this third session in our Aboriginal Health and Wellbeing virtual education series. I'll now pass over to Trixie for an acknowledgement of country before we get the presentation started. Thanks, Trixie.
Thank you, Katie. Good morning, everybody. I'd like to start this meeting by acknowledging the people of the Wiradjuri Nation as I sit here in Dubbo today. I would also like to acknowledge that we work on traditional lands of many Aboriginal nations across our Western New South Wales and pay respect to our elders, past, present and emerging, and acknowledge their continuing connection to land, water, culture, and their contribution to help shape the lives of our communities in which we work and live. I also like to welcome all Aboriginal and Torres Strait Islander Australians who are present in this meeting today. Thank you, and I'd like to hand over to Alison.
Thanks, Trixie, and thanks for that acknowledgement to country. And I too welcome you all here today, and thank you so much for joining us for the third session in this series that we've been working through supporting your mob with diabetes. So today we're going to look at sick day management. And so just to start off the session, we're just going to do a quick poll. If you don't mind putting that up, please, Erica. Just do people living with diabetes in your community currently have sick day management plans in place? How are we going there with our responses?
So Al, I think that's about everybody.
So 11% say yes, 33% say no, and 56% say not sure. And that's probably not a surprising result across the group. I was curious as to what that would be, because sick day management is something that I guess is pretty important, but it's not something that we seem to talk about too often. I think this is a great opportunity to explore that a bit further. I might get you to flick on to the next slide, please, Erica. So when we're talking about a sick day management plan, what do we mean and why should we have one? Does anyone have any thoughts in relation to that? Anyone going to be brave and speak up for us?
Just to sort of help with self-management so that they know what to do when they're sick, what to do with their medication or their insulin, their fluids, how often to check their blood glucose, just to try and avoid them getting sicker or needing hospitalisation.
Yeah, absolutely. So it's about when someone becomes unwell, so they know what to actually do, because often when we're feeling unwell, you know, we might feel a little bit more anxious than normal, or we might feel really unsure about how we should manage it if we don't understand, you know, what's going on with our medications, or what if we can't eat or drink. And so it's about having a plan in place so that if someone does become unwell, they've got that written out in front of them, so that even if they're not thinking clearly, they can see what it is that they possibly should do. And so the idea of that is that we recognise when we're unwell and we act quickly so that we don't become more unwell from not intervening when we should have. And it's also about reducing that anxiety and stress that the person's feeling when they are unwell, so that they're feeling more confident that they know what to do and you know, can keep themselves as well as possible. It probably is important to note that even if you've got a sick day management plan in place, you may still become more unwell and need to seek medical advice. So it's not necessarily about being able to prevent that, but it's about making sure that you're safe. And so that's probably a really important take-home message, that having a sick day management plan in place is about making your community members feel confident and safe that they know what to do when they're not well. We might jump on to the next slide, please, Erica. So who develops a sick day plan? Is it something that the client should come up with? Is it something that you can do with them? Or, you know, who do we think is responsible for a sick day management plan for someone living with diabetes? Does anyone have any thoughts about that? Everyone's really quiet today.
I guess, you know, the diabetes educator and the person can come up with a sick plan, because they're going to have to put some input in who's going to be there to help them, phone numbers, contacts, all those sorts of things. So maybe just a collective effort with the patient and maybe the diabetes educator.
Yeah, absolutely. So their healthcare team, usually them along with either their GP or their diabetes educator, it's usually signed off on by a GP. So because we're sometimes looking at what to do with medications and suggesting people may need to withhold medications at certain times, we really do want to make sure that the GP is happy with the plan that's been developed. So it really is important that it's part of the healthcare team, and that information is sort of shared amongst everyone in that team. And so I guess when we're thinking about that, the purpose of today is not so much about you being able to develop a sick day management plan, but it's about being able to have those conversations with the members in your community and talk to them about the importance of having a sick day plan, and, you know, have those conversations about why it would be of value, what it could involve, and encourage them to go along and get those plans put in place. And, you know, depending on what your level of involvement is with your clients, it may even be of value to go along with them to see the educator or see the GP and support them in making sure that they get the actual information they need down in a way that they can clearly understand it, and it's organised for them for when they do become unwell. Alrighty, so
and now having like your family or your carers aware of the plan and getting them involved, and, you know, knowing that if they're at home at any time and they are feeling sick, and they just know what signs and that to look out for. And
absolutely, Trick. So a really important point. It leads really nicely into our next slide about what should a sick day management plan involve. So Erica, if you'd like to bring up what should it include. And, you know, that's a really important point, that it should absolutely include the family or their support person or those around them. And it can be really helpful to identify who they're actually going to have as their main support person. Again, you know, if someone's feeling unwell and are not thinking clearly, it might skip their mind to actually let someone know that that's how they're feeling, and they might just disappear and go to bed for, you know, for the day or whatever it is. So having that name written down, having how they're going to contact them, even maybe having it written down that you need to let this person know that you've started to feel unwell, or that whatever's happening is happening, so that it's not a matter of the support person comes along 12 hours later and finds them unwell at that point. So even just having simple instructions like that written at the start of a sick day management plan can be really important. What other things might we look at putting into a sick day management plan? Anyone feeling brave?
Just Katrina from India. I guess some of the other things that may need to be adjusted, maybe their medication. So it may be if you're on insulin, the dosage, you know, adjusted, or if they're vomiting diarrhea and maybe they're on metformin, it could need, you know, stopping for a few days.
Yep, perfect. We absolutely need, if they're on medications that need to be stopped or adjusted, we need to include that in their sick day management plan. And so if they go to the doctor and they've had a change of their medications, we need to make sure that that's reflected in their sick day management plan again. So they may not have previously been on metformin and now they are, and so that might become a consideration. So absolutely, we need to look at what they should do with their medications if they become unwell. What other things might we need to consider?
Maybe weight loss or weight gain, because if they've lost weight and they're on insulin, it might need titrating.
Yep. And sometimes if people are, have renal disease or something like that, and they're in the habit of needing to weigh themselves daily in relation to their fluid, you might build something into the plan about, if they're, which they usually have some instructions about what to do if their weight does go up by a certain amount to do with their renal function. We might need to have a sick day management plan kick in at that point. When we're thinking about sick day management plans, we're thinking about generally that sort of acute onset type of illness. So, someone might find that their sugars normally sit around 8, and then all of a sudden one day it's 12, and they really can't explain what's contributed to it. And if they recheck it, it's now 15, and they haven't really done anything differently, and something's not feeling right with them, or they might have cold and flu symptoms. So a sick day management plan is probably more directed at that acute sort of episode of illness. Whereas some of those changes where our insulin dose is not correct and we get weight loss or weight gain over time, some of those can be a little bit harder to pick up on, like an acute episode, because they'll develop gradually and it sort of creeps up on you, if that makes sense. But yeah, thank you. Anyone else got any thoughts on what else we might need to look at as part of a sick day management plan?
I think just making it simple, those forms on the screen look great because they are like quite simple, and they're not too crowded, because sometimes it's too, like when you're feeling sick, the last thing you want to do is read an essay. And even just as part of that plan, having like your sick day kit, like all the things that would be good to have, in a box ready to go, with some hypo fluids or some low zero cordial plus some normal sugary cordial or something, so that you're not then feeling sick and having to go out and get stuff.
Yeah, fantastic. Yep, they're really great ideas.
And checking it every few months to make sure it's all still there and not needing to get more supplies. Yeah, because that's, we can put together something and then put it in a safe place, and then if we don't use it for 6 months, and then we don't, the last thing we want to do is, when we do need to go and use it, is find that it's all out of date and it's not able to be used anyway. That's a really good point. All right, so Erica, if you want to flick on to the next slide, we sort of have covered off on a lot of this, but it's when to start and finish using the plan is really important. So having some prompts for people about when it might be appropriate to actually start your plan. So is it when your sugar's higher than it should be and you can't explain it? Is it when you start to get symptoms of feeling unwell? And making that clear for them, so that they're not doubting themselves as to whether they should or whether they shouldn't. It's trying to relieve that little bit of anxiety. Having the support person's name and number on there, or making sure that they know who they're telling. Checking their sugars more often can be really important if someone's unwell. So there's plenty of people out there in the community that have type 2 diabetes and aren't monitoring their sugars at all. And so, their sick day management plan will possibly look a bit different to someone who's monitoring their sugars daily or twice a day, because someone who's in the practice of monitoring their sugars will pick up that their sugar's high, or they can check their sugar a little bit more closely when their sugar's sort of outside their normal range. So it might be for someone who's not in the habit of monitoring their sugars, it might be that they, their prompt might be, if you've got symptoms and you're feeling unwell, reach out to your support staff, reach out to, if they're connected with you as an Aboriginal health worker, or if they've got a practice nurse or a chemist or someone they can reach out to. Maybe their cue on their sick day management plan is have your blood sugar level checked. If we're not expecting that people who don't monitor their blood sugar levels and haven't previously known how to do that suddenly be able to do it because they're sick. Like, that just adds extra stress. But it's about recognizing that their sugar could be high and prompting them to, reach out to you guys or reach out to someone to check it if that's the case.
Another thing that's probably becoming a bit more talked about and probably a little bit more important than you know, we've previously seen it over the years when we're thinking about type 2 diabetes is checking for ketones. And so that in itself is a bit like checking for blood sugar levels, but we're using ketone strips, and we talk about that a little bit further on in a minute. We've talked about what to do with their medications. The other thing that can be really important is what they need to do in relation to, you know, dietary intake. If they can't keep anything down, or if they've got gastro, or they're feeling really nauseated, what do they need to do, or, you know, what sort of intake is required for them to stay safe, and what should they do if they really can't achieve that? And then importantly, having on the plan also those emergency numbers, or where they're going to go, you know, if they need to access further medical attention, despite doing the things that they've already done. So we might flick on to the next one about blood sugar monitoring. And I did sort of go into this a little bit when I was on that other screen. But it's about, do they know how to monitor their levels? Is their meter and their strips in date? So if someone's got a meter at home and they're only checking their sugars every now and then, or they used to check their sugars and they've got one in the back cupboard, and then they get unwell and they're told to check their sugars, are their strips going to be in date, or are they going to have expired 3 months ago? How old's their meter? So, you know, we rely on our blood sugar meters being fairly accurate. So if they've got a meter that's 5 or 6 years old, or if it's just a meter that they've picked up as a freebie from some, you know, pharmaceutical company doing a promotional event, or, you know, is that meter actually accurate, and are the readings that they get going to be accurate to reflect what's really going on? How are they going to record their sugars for you to let you know what they are when they're unwell? So do they need a, you know, like a diary page or something attached to their sick day management plan so that they can write down what their sugars are? Or have they got a diary that they normally keep their sugars in, that they're just going to write them more frequently in that diary? And really importantly, what levels should they be worried about? So, you know, knowing what levels are considered normal for them. At what level do they need to put their sick day management plan in place and be monitoring it more closely? And at what level do they actually need to seek further medical attention? So that'll be visualised for each person, depending on what their normal sugars are. So I've just got a slide in here on the next one, just looking at what the steps for blood sugar monitoring are. And you're probably already very familiar with this. I guess it's just about making sure that the readings that they're getting are accurate. I have gone over what we've got there on the screen in relation to the meter. Probably the only one was in relation to the strips. I mentioned that they might expire. The other thing to be mindful of is that they're temperature sensitive. So if someone's got their strips stored, say for example in the glove box of a car, and it's the middle of summer and that car might get to 50 degrees or more inside, then that's potentially going to damage those blood sugar strips. So one, they may not work, or they may not give accurate readings. So that's another thing to consider in relation to the blood sugar monitoring. And the other one is just stressing the importance to your community members about washing your hands beforehand. So if someone has had something sticky on their fingers, or something that, you know, might impact on their sugar levels, they might get an artificially high reading. And if they wash their hands and do it again, they might find that it's a different reading. Again, we talk about there being a 10 to 15% variation in sugar levels with some of our better meters. So it's not unusual if you do get maybe a millimole or so difference, but you shouldn't be getting like 6 or 8. You know, you shouldn't be able to take it and then recheck it and it's either 6 or 8 millimoles higher or lower. So that's just something else to be mindful of. And the only other thing would be, if ever anyone's got any questions about their blood sugar monitoring or their machine, just sort of make, you know, it's about building that comfortable relationship with them so that they feel comfortable to ask, because sometimes people you know, you get so far into having diabetes and there's this assumption that you know what they're doing, and they don't feel confident to let you know that actually I really don't know how to use my machine, or I'm having this trouble and I don't know what to do about it. And so they may pretend they're monitoring or be, you know, making up sugars, or so it's just about creating that environment where they're comfortable to let you know if there is any issues and if there is any questions in relation to that. So we might jump on to the next one, please, Erica, about ketones. And some people with diabetes, it's really important to check for ketones. Ketones are essentially a byproduct of fat metabolism. So you may have heard of keto diets that people go on when they go on low carbohydrate diets. So they're burning fats for energy. And so the byproduct is these ketones. So, you know, it's can be quite normal that if someone has been unwell and, you know, not been able to eat or drink, that their body might be producing some ketones. But for some people with diabetes, you can develop this dangerous health condition called ketoacidosis, which you may have potentially heard of, where those ketones accumulate in the body and they start acting like acids, and then the person becomes really unwell. So the idea of monitoring ketones is to pick up if, one, we have ketones present and whether they're at a level that's of concern for that person and whether they need to do something about it. Previously, ketoacidosis was usually something that we would link with people with type 1 diabetes, whereas with the introduction of some medications that we see for type 2 diabetes, it's interesting that we're starting to see it a little bit more in that population group as well. And it's more likely to occur when someone's got signs of dehydration. So if someone is fasting for a procedure, or if they've got some sort of gastro illness where they've been unable to keep any food down, and so they're getting quite dehydrated, that's probably a red flag to be thinking about ketones. And there's certainly some medications that we like to stop in those situations just to minimise the risk. We often see high ketones and high sugars together, and that's your classic ketoacidosis. But also there's another condition called euglycemic ketoacidosis, and that's where we see normal blood sugar levels but high ketone levels. And it's often a result of people taking medications like Forxiga or Jardiance. And so the way those medications are working is they're getting the sugar out of our body through our kidneys. And so it sort of masks that high sugar, high ketones effect that we're typically used to seeing. So generally, as I mentioned, we would say that people are at higher risk for ketones if they're on a low carbohydrate or restricted diet and then becoming unwell, if they're fasting, if they've got a gastro illness, if they're doing sometimes bowel preparation for a colonoscopy because they're not eating and drinking as normal and they're having the washout prep, and also excess alcohol intake. So we often see dehydration following a heavy alcohol intake, so that's also a risk. The signs and symptoms of ketoacidosis, well, actually that's on the next slide. I might get you to flick over if you're happy, Erica, thank you. Signs and symptoms of ketoacidosis is abdo pain, nausea and vomiting. That's really classic. But again, if someone's got a gastro illness and they're already got those symptoms, it can be hard to distinguish it. So not being able to keep any fluid down, having persistent vomiting, having a fruity odor to the breath. So that's a really classic sign that someone's got higher ketone levels. And so it's quite distinct. And then as it gets progresses, you'll start to see them feeling drowsy and sometimes a bit confused and weak. When we're thinking about ketone levels, I guess it's understanding what the normal ranges are. So for someone to be able to check their ketone levels, not all blood sugar machines can do that. And so the Freestyle Optium Neo or the Freestyle Libre readers are able to check ketone levels. And I've got them on the screen there. There's a Care Sense meter and a Life Smart meter. But it's really important to know if someone has a meter that can check ketones. And then the other thing that's important is it uses different strips. And so those strips aren't covered under the NDSS. And I checked with the pharmacy last week, and for a box of 10 strips, it's usually about $11 or $12. So you're looking at maybe $1 a strip. So if you've got written into your care plan that you want someone to check ketones and you want them to check them every 2 hours, that's actually going to end up being a little bit expensive for them. And so if you've got someone who might be at risk of developing ketones and we're a bit worried about it, in their care plan, it might be that they have to access medical attention earlier and they need to get their ketones checked. So it might be either with yourself as their Aboriginal health worker or the practice nurse, just to make sure that just because they're not affording it or they don't want to buy the strips from the NDSS, that it doesn't get parked, that we have to have another way of them getting their ketones checked, because it can make you quite unwell and it's quite a serious condition. When we're looking at the ketone levels, it comes up on the monitor the same as the blood sugar level comes up. And so anything under 0.6, we're happy with. And quite often people walking around in the community will have ketones at that level, depending on what they've been eating and what level of activity they're doing and that sort of thing. If it's between 0.6 and 1.5, that's the range that we go, it's a little bit up. We just need to keep an eye on that. They may normally sit there, or it might be that it's starting to creep. So we would want to recheck that again in 2 hours. And if it's above 1.6, they need to go and get medical attention, because that's starting to get into that range that we're concerned about. Does anybody have any questions about ketones or ketone monitoring? Is it something that you've heard about before? I know when I was working in general practice, it was something that I wasn't totally familiar with, and it's probably only since stepping into my role into diabetes education that I've got a better understanding of, I guess, the importance of ketone monitoring. And it wasn't something that we were talking about a lot in the environment that I was working. And so if anything, if in doubt, raise it, and then the GP can either say, yep, that's a good point, let's consider that, or no, I don't think this person's at risk. But even if it's just knowing that sometimes people need to monitor ketones and that you raise it with the team, that might be the difference between them getting access to it and not. Yep. Alrighty, we'll flip on to the next slide, which talks about medications, and we touched off a bit on this before as well. The main thing being that some medications may need to be stopped, and some medications or some may need to be reduced. And another thing that can be really helpful to include is when should they restart a medication. So if someone stopped taking a medication, we want to make it clear to them when it's safe to restart taking it again. And a lot of this is around that someone being at risk for getting dehydrated. So the same as when we're talking about them developing ketones, often medications need changing when someone's not able to eat and drink normally and they're sort of at risk of getting dehydrated. So someone mentioned it before and they were spot on that often metformin needs to be withheld when someone's dehydrated or fasting for a procedure. So that if someone's on metformin, and we often see that in the community, it's probably, it's our first line medication for treating diabetes. So a lot of people may have in their treatment plan that if you're unable to keep anything down or you can't eat and drink, if you can't eat, essentially, withhold your metformin until you're able to eat again normally. And that might be reasonable. It's probably also important to explain that when they're withholding medications, we're likely to see our sugars go up because that metformin would normally help keep our sugars at a good level. So not only is it the stress on our body that they're unwell, that their sugar might go up, but we're also withholding some of their medications, which may contribute to it going up even further. The other medications we need to be particularly mindful of are the what we call SGLT2 inhibitors, and I mentioned them before. The two brand names that we typically see are Jardiance and Forxiga, and so any medications that have a combination of metformin with either Jardiance or Forxiga, or either those medications on their own. If someone's becoming dehydrated, then we need to see those medications stopped and withheld until they're able to eat and drink again normally. And another one, or another couple, ones where we see higher insulin levels. So sulfonylureas, which are like our diamicron and our glycoside, they're causing our body to make more insulin, whether we're eating and drinking or not. And so if someone's unwell and they're not able to eat anything, sometimes by taking a medication such as diamicron, that can cause our blood sugar level to drop too low. Anyone who's on diamicron should be able to check what their sugar levels are, because they're at risk of potentially having low blood sugars from that medication. So they should really know how to monitor their sugars. So it might be in their sick day management plan that if they're unable to eat and drink and their sugar is below 6, don't take their diamicron. You know, something really clear for them to follow, because if they're unable to eat and drink, but the stress response on their body is causing their sugar to be high, then it's quite reasonable that they take their diamicron. But if the fact that they're not able to eat or drink is actually causing their blood sugar level to sit low, then we don't want them to take their diamicron. And it's a similar thing with insulin. So if someone's unwell and their blood sugar level's high, we want them to continue taking their insulin, and sometimes they might need a little bit extra insulin. But if somebody's unwell and their sugar's sitting low, by taking that extra or taking their normal dose of insulin even, that might be enough to cause them to drop too low. So, you know, it's really individualized to what your community member is normally taking and how they should manage that. And again, as I mentioned at the start, it's not your responsibility to know what to do with all these things, but the idea of getting more familiar with it is so that you can recognise if what someone's got in their recognise if someone has a sick day management plan to start with, and then recognise if what they've got in their plan is appropriate for them, and if it's got everything in it that it needs to have, or whether there's some other things that they could be thinking about. Does anybody have any questions in relation to medications, or, you know, something doesn't sound right, or you're not sure of something I've said in relation to some of those scenarios with medications? Everyone's feeling okay with that? So another thing that can be really helpful is, what do I do if I can't eat and drink? You know, what should I be doing? And you've told me that it's really dangerous if I get dehydrated, but I'm feeling really nauseated and I'm struggling. So if someone's unable to eat or drink anything at all, they need to seek medical attention. It's usually about 4 hours. If you can't even tolerate a sip of water, you probably need to seek medical attention at that point, if that's gone on for 4 hours or longer. Often people won't be able to eat normally, but they can tolerate a little bit of fluid. So we try and say aim for between half a cup to a cup of fluid each hour. And, you know, you can even break that down even further, have 10 mils of liquid every 10 minutes, you know, whatever it takes to get a bit of fluid in. If you need to break it down into smaller amounts, that's reasonable to do that. If my sugar was sitting high, so if my sugar normally sits under 10 and I've got my sick day management plan in place and my sugars are sitting at 16 or 18 and I can't eat properly, so I know I need to have something to drink, what sort of drinks would be appropriate for me to be having at that point, do you think? Has anyone got any ideas? Should the drinks that I'm having contain sugar or carbohydrate, or should they be sugar or carbohydrate free?
So sugar and carb free if their glucose level's above 15. So we're still getting the fluid but not adding to our glucose level. And then if it's
absolutely
below 15, having sorry.
No, that's okay.
Bloody work call. Yeah, so then if it's under 15, have sugar in it to keep their, you know, not going hypo, etc.
Yep, absolutely. So what are some examples of sugar-free or carbohydrate-free fluids that we could suggest? Because again, sometimes if you're feeling unwell and everything's overwhelming, the thought of even thinking, what am I going to have to drink, can sometimes be challenging, or it might be the only thing you can think of without sugar in it is water, and you really don't feel like having water at the moment. You've got an awful taste in your mouth. So what are some suggestions that they might be able to have if they wanted to have a sugar-free or carbohydrate-free liquid?
Alison, what about all the diet or the sugar-free cordials or something like that?
Yep, could go with the diet cordial.
Sugar-free soft drinks or?
Yep. So sometimes like a bit of lemonade or something
Yeah.
can make you feel a bit better if you're really nauseated. So maybe a sugar-free lemonade.
Aaron was asking if hydrolyte would be okay.
Generally, I think it is. I haven't got it on my pictures. There's actually not much carbohydrate. So it's not carbohydrate free, but it's got low carbohydrates. Well, they're the sports drinks, the Gatorade. So yeah, I think hydrolyte with the replacement of the electrolytes, absolutely. Yep, because it doesn't have a lot of sugar in it. What about like a broth? If someone's after something savoury, like a broth or a stock, as long as it doesn't have sugar in it, or a yeah, like a soup without carbs in it. Yeah. So sometimes if someone's looking for something savoury, they might be an option. What about if high blood sugar levels is not an issue? Actually, Erica, do you want to pop onto the next slide? That'll show the summary of what we just talked about. I think we've, diet jelly.
Jelly, yeah.
That was the other one. Sometimes having some jelly when you're feeling unwell can make you feel a little bit better. So, but yeah, I think you guys are all over it. It's just knowing what those sugar-free options are, and sometimes having those pictures or just having it written down, having a supply of it in the house. It's just that reminder so that when someone's feeling overwhelmed and not great, it's easy and it's accessible and it's not a chore. So if you're lying in bed, unable to keep anything down, feeling really, the last thing you want to do is to the shop and get something because you can't eat or drink what you've normally got in the cupboard. So yeah. So on the next slide is if your sugar's not high, but you just can't keep anything down. So you can see it's all of those essentially similar to the things we had when we're talking about carb free, but they're the ones that haven't been sugar reduced. So a bit of fruit juice, normal cordial, milk's got carbohydrate in it. Often people don't feel like having milky drinks if they're upset in the stomach. Regular jelly, regular icy poles. But yeah, does anybody have any questions about that? No, all good, making sense. All right, so where would I keep a sick day management plan? Everyone's really quiet today. Sorry.
I just saw like in your medical files, maybe with your little kit that you've got for sick day management, like with all your other stuff that you've got, and then maybe, I don't know, on the fridge, or give it to someone too, one of your family members, if they need to help you as well.
Yeah, that's a really fantastic idea. So if you've got someone listed as a support person in your sick day management plan, or if it's just someone that you're close to or someone that's likely to be around you, if they've got a copy of it, fantastic, because then they know what to do if you're not feeling up to it. And when your sick day management plan is developed, your healthcare team should also have a record of that in your medical file. But probably the biggest thing is make sure it's somewhere accessible. So don't put it in a really safe spot at the back of the cupboard, so that when you're feeling unwell, you're not actually going to be able to remember where you've got that tucked away. It needs to be somewhere that, you know, it's easy to be seen, it's easy to access, because the whole idea of it is just keeping things simple and, you know, minimizing stress when someone's not feeling their best. And then I might get you to skip to the next slide, please, Erica. But it's really important to review your sick day management plan after you've used it. So if someone has been unwell and they've put their plan into place, and it didn't feel right, or they still had doubt, or they were really unsure, it's really important to revisit that. And what can we do differently so that next time they feel better about managing when they're not well? The other time it's really important is if they've had medication changes. So if someone was previously, you know, on metformin and then they got Forxiga added in, it's really important that the medication is updated in their sick day management plan to say they need to withhold both. Or if someone, you know, has a medication added in that they don't need to withhold, it's really important that they know you're going to stop the metformin, but you're going to keep going with Januvia or something like that. So just making it really clear, but making sure we do update it when things change. That's probably the biggest thing with that. And just remembering that often, even when people do have a sick day management plan in place, they may still become unwell, okay? And the idea of the management plan is to try and keep them as safe as possible, and so that they access further medical treatment at an appropriate time. And so it's not necessarily going to stop them becoming unwell, but it means that they're going to access the care they need when they need it. Jennifer, I think it was mentioned earlier about having a sick day kit at home. If we were going to keep our sick day kit stocked and ready, what sort of things are we going to put in it?
Yeah, ketone strips, glucose tablets, some insulin if you need to. Obviously, it's got to be kept in the fridge, but just needles, things like that.
Yep, definitely. Copy of our plan. Anybody else got any thoughts on that? Definitely. Oh, sorry.
Oh, I was just going to say, like just who to contact, you know.
Yeah, definitely.
Phone numbers. And even if they just had, like, you know, some jelly beans, or they had their dog drinks and their full sugar drinks.
Yep, perfect. And updating phone numbers. So a lot of the stuff we've got in the sick day management, the sick day kit, are things that we need to keep an eye on. You know, like if we've got phone numbers in there, have those phone numbers changed? Has someone got a new mobile? Do we need to update that number? Because the last thing we want to do is find that we've got the old number when we're not feeling great. Having treatment for if our blood sugar level's too low, having those fluids that we're going to have if our sugars aren't low, or if they are, if they're not high and then they are high. Maybe keeping a pen and paper or somewhere to write their sugars down in there. And then, so if we're thinking about ketone strips, blood sugar strips, foods, perishables, well, not perishables, but things that are going to have an expiry date, it's really important that we keep an eye, you know, how often do we need to check that sick day kit to make sure that those things haven't gone out of date. Some people might even keep things like Panadol, or if they have medications at home to help with nausea, so that if they do have nausea and vomiting, that they can take medication to relieve that. That might be in your sick day kit as well. Alrighty, so we might have a bit of a look at hypoglycemia, because that's one, you know, that if someone's on medication that puts them at risk of dropping a bit low, we see it, it's not uncommon in the community to come across it. So what sort of level would a sugar be for us to say someone's having a hypo?
less than 4, Alison?
Yeah, absolutely. And so usually we'll see that if there's been a bit of a mixed match between medications that they're taking and their activity level or their dietary intake. I think we talked about this in one of the earlier sessions, that having type 2 diabetes doesn't put you at risk for having hypoglycemia. It's if you're using medications to treat your diabetes that can potentially force your sugar too low, then that's where the risk comes from. So if you're taking insulin, or if you're taking a sulfonylurea like diamicron or glycoside like we were talking about earlier, those are the medications that they're the people that we need to know their risk for having a hypo, and make sure that they have a clear understanding of what to do about it. So we can probably start to bring up those things on the screen there. So it needs immediate treatment. If I say, for example, we'll go on to a poll. If I have a low blood sugar level, but I don't feel unwell, so my blood sugar's dropped below 4, but I feel pretty normal, say I've got a reading of 3 or 3.1, do I need to treat that? Do you think I need to treat it as a hypo, or do I, because I don't have any symptoms, I'm okay to keep going? And if you don't know, it's okay to put that you're unsure. Fantastic. That makes me really happy. Well done, everyone. So you absolutely need to treat it. So I won't spend too long talking about this because you already know the answer. But sometimes when people have had diabetes for a long time, or if they're having frequent episodes where their sugar drops too low, they can have what we call impaired hypoglycemia awareness. And so their body's not as good at letting them know when their blood sugar levels are getting low. So for people like that, we can't rely on their symptoms as an indicator of their sugar dropping low, and they need to actually check fairly regularly, or in situations where there may be a risk for it, they need to know to check to make sure that their levels are safe. Because even though they haven't got symptoms, their brain's still at risk of not getting enough sugar and not being able to function. And in fact, it's quite a significant risk in that when someone gets symptoms and their blood sugar level gets to 4, you've got a window of time to treat that, to bring it back up. However, if someone's already down to 3 before they're even getting any symptoms, then the window of time they've got to treat before they drop into levels where they may become unconscious is a lot less. So it's something that we need to be mindful of. So what are the typical symptoms of someone having a hypo?
Can be different for each person. So sometimes they might just look pale or something. So letting their family know, or whoever's with them when they're having a hypo, because sometimes they may pick it up and go, oh, you're looking a bit pale, can you check your blood glucose before they even feel it themselves? Things like, tremor, feeling hungry, headache, feeling shaky, a bit cranky, sometimes, might be a bit moody. So it might actually be a hypo, not just bad mood.
Yeah, absolutely. And sometimes people will just say that they just don't feel right. They just feel something's not right. That's a really common response, that they know something's not right. They can't put a name on what they're feeling, but it's just this feeling that something's not right. So if ever, and if it's, the message we share is if ever there's any doubt you're not feeling well, something doesn't feel right, just check your sugar. There's no harm in doing it. And sugar, the strips for your blood sugar meters are free. So if someone's on a medication that they have a risk for hypos, then if ever there's any doubt, just check your sugar. So
Al, Chris has just popped in a couple of other suggestions: slurred speech, pale, sweaty, and palpitations.
Yep, absolutely. Thank you, Chris. So if you want to flick on to the next slide, Erica. So this is off the Baker Institute, they have some resources around hypo management. And so I actually really like the one that they have for how to treat a hypo. Did we cover off on all of those? Sweating, headache, hunger, shaking, lack of concentration. So usually the lack of concentration and then the dizziness and the blurred vision and those neurological symptoms will come when the further your sugar's dropping, because they're signs that you're really not getting enough sugar to your brain. And then obviously that going unconscious is what we want to avoid. So on the next slide is the treatment that is written up for on the Baker Institute resource. So I find this one a good one to hand out. But you know, any resource, if it resonates with your community members, so you might have one that you know, is worded differently, or you feel is more applicable to the community group that you're working with, and that's absolutely fine. The key messages are, you know, checking your sugar if it's low, having some carbohydrate that's going to work really quickly. And so often what you'll find is if someone's had a hypo and then you talk through what they did about it, you know, there was a Mars bar sitting there, or there was a Snickers sitting there, so they had that to bring their sugar up. And it's about having that conversation that you need straight sugar. You need something that's going to hit your stomach and get absorbed into your blood and bring your sugar back up pretty quickly. And so anything like chocolate or anything that's, you know, our body needs to take time to break it down is probably not going to be as ideal to treat a hypo. And then talking about how much carbohydrate they need. So if someone's got a packet of jelly beans sitting there, their sugar drops low and they eat 30 jelly beans to compensate for it, then we're potentially going to see, you know, their sugar go really high afterwards. And then that's going to be a management challenge in itself. So, you know, if I'm having jelly beans, I want to have sort of 6 to 7 jelly beans. Or if I'm having soft drink, it's not to be my diet soft drink that I normally have. I need it to be regular soft drink, and it needs to be half a can. And then rechecking your sugar. And if it's still low, then retreat it. And, you know, if you've checked it 3 times and you've treated it and you haven't been able to get it back up, you know, you need to seek further help. If you've checked it and it has come back up and you're not due to have one of your regular meals, talking about that, having something to stop it dropping again and what options they might be able to have at that point. But I feel like managing hypos is something that we definitely talk a lot more about compared to some of the other things that we've talked about in our managing sick day plans. Does anybody have anything further they'd like to contribute to that, or any questions?
Sometimes people, if they're on insulin, I find if they're having a hypo before a meal, like explaining that no matter when the hypo happens, fix it first. So they might go, oh, I didn't just have my insulin and I just ate my dinner. So explaining you need to fix the hypo first, then you can still have your insulin because that's covering the carbs in your meal, but you've like stopped the hypo happening to make it then safer for later. Because then by the time they eat their meal, if it's got, you know, fats or other things in it, it's not going to bring their glucose up quick enough. So they actually need to fix the hypo first.
That's a really good point. Thanks, Jennifer. And I also like the point that you raised about, you know, they're going to have their lunch and they're going to have insulin with lunch. And so they just eat their lunch and don't take their insulin as part of the treatment. But again, they're having lunch, which is going to cause their sugars to rise, and they need their insulin to compensate for that. So by not having their insulin, they're going to run into trouble later on. So I think there was a couple of really important messages that you shared there. One about treating the hypo first, but then the second one, if someone's having mealtime insulin, even though they've had a low, they still need to take their mealtime insulin with their meal because it's addressing what it is they're eating. Yeah. Alrighty. Well, I think this is absolutely amazing because I think we've gotten through the planned information that I wanted to share with you, which I've struggled to do on the last 2 sessions. I've got some resources up on the screen there. There's quite a number of resources out there to support people when talking about sick day management. So the Australian Diabetes Educator Association has some guides in it that has some sick day plans that you might want to use as a template. The NDSS has got information on sick days for people with type 2, so similar to the information that we've talked about today. So it's not giving them an exact plan on what they need to do, but it's giving them information about things that need to be considered. And you might find those resources useful for yourself, just as a bit of a reminder as to what's important or why it's important. The Baker Institute, the Baker Diabetes and Heart Institute, they have some really great resources, and I often refer to those because they include lots of pictures on their resources, so that can be really helpful. And if you're working with the healthcare team and all you've done is say they've got diabetes, should they have a sick day plan in place, and then the GP wants a bit of guidance with that, all the information around it is in their RACGP handbook. So, if you're working out in the community and the GPs aren't really confident with putting together a sick day plan and you haven't got an educator that you can tap into, that's a really good handbook resource for the GPs to refer to get a bit more information on what you're talking about. Or you might take to them a printout of one of these other resources, just so that, they may not, at the start of the session, we said we're not seeing a lot of sick day management plans out there in practice. And so it's about starting to talk about it and starting to get people to think about it and what they want it to look like and what they want written down. So that brings us to the end of today's session. There is an opportunity. I'd love it if someone was feeling courageous enough to share any of their experience around either supporting someone when they've become unwell, or if you've got a scenario where someone didn't have a sick day management plan in place and what the fallout from that was, or if you've got a scenario where you have supported someone to develop a sick day management plan before. Is there anyone out there who's feeling brave to sort of share some of their lived experiences with us?
With those, the glycogen hypo kits, like if there's no demo kit for those, I often have patients, I don't know if I'm supposed to do this, but patients when their kit's expired, I've got a couple of them, I feel like it's Christmas when they bring it to me, they give me their expired kits. So when I go to schools or groups or talk to patients, I'm a very visual learner, so I like to be able to see stuff, feel stuff, all that sort of stuff. So I then have some I can show what they look like before it's mixed up, how to mix it up. So it just gives them a bit of an idea. So then teaching getting them to bring their family member in to have a look at it. And I was at a conference once and there was a couple of educators there. One lady has type 1 diabetes and her roommate, who's also an educator, she had to give glycogen to her roommate who was having a hypo. And I think just understanding that even though we learn about these things, she said she was shaking so much and really nervous because she's learned about it and done it stuff, but this was doing it to her friends. So I think letting families and stuff know that this is really, scary. You're sort of, helping someone, but it's, especially they're usually fairly out of it, so they're not going to feel it. But just letting them understand that you do get that it is scary having to do that for someone.
Yeah, really good point. Thank you. And I agree. It's really easy to talk about this stuff, but to actually get familiar with it and be going through the processes yourself is a different thing altogether. And thank you.
I suppose, Alison, another thing too, we've had people ring up who I'm personally not familiar with, and they've asked questions about what they do and whilst they're actually sick. So I think that point of having a record of their sick day plan with their healthcare team can really help those, because if the person they normally speak to isn't there, it's just easier for someone that is there to talk to them to quickly look up their sick day guide and actually talk them through it over the phone as well. And the other thing too, like those ketone strips, we've had someone when they had COVID who had type 1 who was like, I'm feeling unwell, my blood glucose levels up, but I don't have any ketone strips and I can't leave the house at that particular time. So just making sure that those strips are in date, or that they've even got some to start with, can make a big difference for the person if they're by themselves.
Yeah, definitely. And that because people aren't getting sick all the time, it's really not uncommon for that scenario where they don't have ketone strips, or the ketone strips have expired, because, you know, if you're paying an out-of-pocket $10 or $12 and it's sitting there and you never use them until the day you do need them, you know, people, it's really easy to not replace them. So yeah. Alrighty. Well, thank you everybody for joining us today. Erica, did you want to talk through the evaluation?
So everybody, there's a QR code on the screen now. If you could just scan that with your mobile phone, or I have sent a link in the chat. If you've attended more than one session, we'd love to have your feedback for the series as a whole. We'd be interested to know whether you want these sorts of sessions to continue, and if so, what you'd like to hear about. But I also just want to take this opportunity to thank Alison for sharing her knowledge and her insight. It's been wonderful, Al. Thank you so much.
No, thank you. And thanks everyone for engaging for the subsequent sessions. You know, it's really nice as someone who's trying to share information to know that you're keen to come back and learn more. So I really appreciate everyone's participation.
Yep, and Trixie and I'd like to second that. We've loved having your company over the last couple of weeks. So thank you all very much. Have a good afternoon. We look forward to your feedback. Thank you all.
Yep. Thank you.
Take
Thank
care.
you, everyone.
Bye.
Bye-bye.